number of these risk alleles, particularly of European descent. What's the future? Well, there's a global consortium, the Cardiogram study, which is looking at a genome-wide study, looking at 20,000 coronary disease cases and 60,000 controls, looking for other common variants. And there's also increasing effort being done to look at the very rare variants at less than the 5% minor allele frequency. The 100 Genomes project is the best example of that. Similarly, there's a lot of work done looking at characterizing genes that seem to affect other risk factors such as dyslipidemia, hypertension, diabetes, because of the likely common mechanism behind the whole process. What then can I say about the GenCAD study? Well, following a meeting not more than a mile from here, it seemed too good an opportunity to pass up. There's a very large database of people, many worried well, who've come through the scanning centre and had their coronary calcium score done. There's a very good clinical database. And coronary calcium, we know, is an intermediate phenotype, is a marker of disease that's present silently in many people. But what we were able to do is take that as a resource and then look at the impact of genetic polymorphisms that have been identified through genome-wide studies and to see if there's any association in coronary calcium scoring to try and put another piece of the puzzle in place. As has been mentioned, we know coronary calcium is a marker of coronary disease. And again, quoting Gary Mintz from about 12 years ago, as calcium is a marker of plaque burden, and the greater the plaque burden, the greater the likelihood of there being potentially unstable, invisible fatty lesions. So calcium in turn may be a marker of future events because it's a good marker for the underlying disease burden. These sort of graphs are quite common now, that you can have age, sex adjusted graphs of calcium scoring. So if you're in your 40s and your average, your calcium score should be sort of 30 or below. Some people obviously fall even lower than that, and some people have very high risk scores. And we know that if your calcium score is above 1,000, you know, your risk to event myocardial infarction or cardiac death with 1 year, and this is often unheralded, can be as high as 1 in 5. So we know coronary calcium potentially is a very useful surrogate to use, the so-called intermediate phenotype. So in the GenCAD study, we've taken a lot of the data from these well-publicized genome-wide studies looking at the possible genetic markers, and we started to look to see is any impact of these markers on coronary calcium. The data I'm going to show is all by courtesy of Professor Samani, and the data I would like to present is just looking, and it's a snapshot of the effect of the 9p21 locus on coronary calcification. A total of 589 samples were used. About 515 have been included in the analysis. It's an all-male Caucasian population of 194 controls who had calcium scores of 10 or under, all aged over 55. There's 321 cases whose calcium scores were above 100. The data was associated with the appropriate logistic regression models accounting for the standard risk factors, age, blood pressure, diabetes, smoking, family history and BMI, and then non-parametric statistical analysis looking at the difference and the effect of the genotype on coronary calcium. And there does appear to be something in it. There is definitely a gradient of coronary calcium. The C is the risk allele, and the mean calcium scores are significantly higher in the homozygous CCs compared with the heterozygotes or the GGs. This is early data, but it's certainly quite intriguing, such that the highest median coronary calcium score is lowest if you have the protective phenotype and highest if you have the so-called at-risk phenotype. The association is significant with P equals 0.02, an association between the C allele at 9p21 and the risk of high coronary calcium with an odds ratio of 1.57. And these results suggest that the mechanism through which this chromosomal abnormality on 9p21 locus appears to predispose towards coronary disease might be through mediating atherosclerosis. But actually, beyond that, we don't know. So it maybe raises more questions than answers. So now this is not even the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. Thank you.
Good evening, Laura, and thank you for asking me to come and speak here. I will try in the next half hour or so to help Laura out on this problem she's had understanding these guidelines. The NICE guideline was a little unusual in that it wasn't the sort of regular NICE guidelines that we're used to, which look at the effects of treatment of disease, and which, of course, draw upon randomized trials and so forth to determine whether or not drug A is better than drug B, and then to advise us on how to treat blood pressure or arthritis or conditions like that. This was a diagnostic guideline looking at non-invasive diagnostic tests for suspected angina. In fact, there was a parallel guideline for diagnosis of acute coronary syndromes, which I'm not going to touch on this evening because I think this is the one that fits best with the subject matter. The problem about recommending different diagnostic tests is that the diagnostic value that we're all familiar with these tests is normally defined in terms of sensitivity and specificity. That is to say, it gives you a measure of how many false positive and false negative results are delivered. And of course, the higher the sensitivity, the higher specificity, the better the test looks. But what you've got to remember is that all the information you look at in developing these scores is derived from an angiographic gold standard. So, for example, if you're interested, as we are today, in tests for suspected angina, then the diagnostic value of the various tests on offer is going to be measured in populations that have been referred for angiography, and you can guarantee, therefore, that there's an element of what's called workup bias. And the kind of patients we're interested in this evening, that is to say, patients with suspected angina, with chest pain of uncertain cause, for those kind of patients, diagnostic value of these tests is always much lower. And that's something we've got to bear in mind. The other thing is that very few of these studies have actually looked at what's called the incremental diagnostic value of these tests. That is to say, you get a history of the patient with chest pain, and you come to a decision about whether or not it's likely to be angina. And so what you're interested in is whether the test will actually add to the power of your diagnostic decision. And in some cases, these tests don't actually add very much. And finally, as I hinted at the beginning, none of these tests, and I mean none, of the various diagnostic techniques available, and this harks back to Amanda's question a bit earlier, have been subject to the rigors of randomized trials with clinical outcomes. And so we've had to bear all that in mind, and that actually just underlines the difficulty in developing guidelines for non-invasive tests. So let's look at this marvelous portrait here of Heberden, who gave this description of angina among descriptions of various other diseases we're all familiar with. And this is a marvelous description here. It's marvelous for the sort of the graphic language that's used. So he talks here about afflicted with it, seized while they're walking, a disagreeable sensation would extinguish life, etc., etc. But the other reason it's marvelous is that it's just concords with everything we know and understand about angina. It's comes on while you're walking, worse up a hill or after eating, disagreeable in the breast, that's in the chest, I presume, which would extinguish life, and goes away when they stand still. So everything that's captured in this definition remains true today. And of course, we're all taught at medical school that angina is a clinical diagnosis, and so it is. And you, by taking a careful history, you can pick out, after before too much experience, whether or not the patient's actually like to be describing angina. Now, this is a slide I put up for medical students. And here we got a brief history. 22-year-old man, grandfather and great-uncle both died of infarcts in their 70s, who's experiencing intermittent, unprovoked left-sided discomfort, often lasting several hours, and he's got a normal ECG. So the question is, what's your first diagnostic test here? And there's a list of potential options here. And of course, this patient does not have angina. 22-year-old man, that is quite clearly not angina. And so the worst thing to do is any diagnostic test. Because what if suppose you decide to do a perfusion scan in this patient, and suppose the patient has an abnormal perfusion scan. What's your response to that? Do you think, well, perhaps he has got angina, better do another test, perhaps even wind up doing an angiogram, or something silly like that? Or do you say, it's not my diagnosis that's wrong, it's a test that's wrong? And of course, these tests are very commonly wrong. And the correct answer, in my opinion anyway, is that you don't need to do any tests in this patient. You simply need to reassure him that the heart's okay and let him go on his way. So let's take another example. A 68-year-old man, smoker, experiences constricting chest discomfort, radiating to the throat when he walks upstairs, associated with shortness of breath, eases gradually with rest. Again, the ECG is normal. This man, obviously, has got angina. There's no doubt about that. That's what that history is. It's angina. And so again, when asking what the first diagnostic test is, the correct answer for diagnosis is none of the above. Because I put it to you, what if the exercise test you do, for example, is normal? Do you say, oh, well, I've got the diagnosis wrong? Of course not. It's the exercise test that's wrong, not your diagnosis. And so this really underlines one of the main recommendations in the NICE guideline, that you trust your clinical judgment when you're looking at patients. And if angina is typical on clinical assessment, and the estimated likelihood of coronary disease is very high, then there really isn't any point in doing diagnostic testing. In fact, diagnostic testing is positively unhelpful because it will commonly give you the wrong answer. And likewise, if chest pain is either non-anginal, pain in the back when you bend forward, that's not angina, or alternatively, if the estimated likelihood of coronary disease in a patient with chest pain, that's the first example I showed, is very low, then don't start putting the patient through a whole battery of tests. Look for other causes if you want to, but reassure him or her that it's not angina. Now these were meant to be big crosses, not mice, but there you go. It's been slightly chewed up by the system. But what this slide shows is one of the illustrations in the guideline, which lists the likelihood of coronary disease in a patient with stable chest pain. And chest pain is defined in terms of whether it's non-anginal, atypical, or typical. And if for the chest pain to be typical, it's got to have the constricting character, it's got to be provoked by exertion, and relieved by rest. You've got to have 3 out of 3 features. If you've got any 2 of these, you've got atypical angina by definition for the purposes of this, what I'm showing you here. And if it's non-anginal, you've either got none of these or just 1. And the likelihood of coronary disease, of course, and we're all familiar with this in our day-to-day practice, is determined by the gender of the patients. Younger men are more at risk than younger women. The age of the patient, as you get older, all these numbers go up. These show you the risk of disease. And whether or not they're at low risk in terms of risk factors, and that's defined within the guideline, or high risk. If you're high risk, of course, then your likelihood of coronary disease is that much higher. And the reason there's a cross here, and a cross there, and a cross there, and a cross there, is that these are patients either with non-anginal chest pain or with a very low likelihood of coronary disease, that's example I showed you a bit earlier, or patients with a very high